We are delighted to have with us today as well Peter Jacobson, who is a professor here at the University of Michigan School of Public Health, another attorney. Peter, Sarah, Mark Hall, and I actually did a somewhat similar presentation at Academy Health in Boston, and I said, so is it only attorneys who really focus on these safety net providers? They're all attorneys on this panel, and they all seem to have a passion around this topic, and it's great because, as Sarah said, the health centers all need good legal environments and good legal advocates. So we're delighted that these attorneys are here helping us. Peter, like Sarah, has long been interested in safety net providers, what it is that can help make them successful, where their opportunities are, where their challenges are. And he is going to share with us today some of the research he's done, actually with funding from our center, among others. And we're delighted to have him.
Thanks a lot, Marianne. Let me first thank the study participants, the people who took their time to help us identify clinics, and then the people at the clinics who were generous with their time in answering our questions. Also to Marianne and Chart for not just the funding, but the support throughout the entire project. And also, we had great students. The three of us were the primary faculty people on this project, Val Myers and Judith Calhoun, but we had terrific student support, some of whom are in the room right now, and we couldn't have done this without them. I think it works out very well to follow Sarah, and I do want to take the opportunity to echo what Marianne said, that Sarah is truly one of the most perceptive health law, public health law policy commentators, and I think you've seen why we feel that way. We have some interesting convergence in our views, but I think some perhaps more interesting divergence, and that's probably what you're going to hear more of from me. So this is a study of organizational and operational efficiencies in Michigan's healthcare safety net. So if Sarah presented the macro view, I'll be talking about the micro view in a series of interviews that we conducted looking at both operational efficiencies and organizational models. Because of time constraints, I will really only be talking about the operational efficiencies, though I'll, in passing this time, mention some of what we found on the organizational side, and happy to address any questions you have about that later on. We started this project before the Accountable Care Act was even discussed, and certainly before it was enacted, so that the nature of the questions that we asked aren't directly related to health reform as such, but certainly I think are important within the context of the Affordable Care Act. In particular, what the Affordable Care Act does is to invest heavily, that is exclusively, in FQHCs, to the exclusion of free clinics and other models. And it's an important contextual piece of this in sort of putting Sarah's and my comments together that we can talk about, and perhaps the panel will want to comment on. So ours is a qualitative study where we conducted a series of interviews asking first a general question about what are the components of an efficient clinic. And then we asked about the strengths and challenges. We asked about the strategies for improving efficiencies. And then we talked about the models. How are you organized? Patient-centered medical home, urgent care, referral model, triage. What's the basic organizational structure? We also attempted to collect as much data as we could. As you'll see, the data quality varied. We also attempted to obtain data from HRSA, and we got back a very heavily redacted report that the students are trying to push through at this point. We're not getting we were unable to get the clarity of information from HRSA that Sarah outlined before. In the end, we interviewed at 29 sites within Michigan, 14 FQHCs, 12 free clinics, and 3 hybrids. Now, we defined hybrids. We defined free clinics as clinics serving no more than 15% of paid reimbursable patients, 85% uninsured. We defined hybrids as those clinics that would take insurance, Medicaid, and any other form of payment, but also have a mission to serve uninsured patients. We did not define a percentage for the hybrids. And as it turns out, we wanted to interview at more hybrids, but were unable to do so within the constraints of the project. We interviewed, as you can see, clinic directors, executive directors, medical directors, receptionists, and other. I have no idea what other stands for. But we did interview others. We did not interview patients for lots of reasons, though there are some really potentially interesting follow-up studies to that. We wanted the view of receptionists because you often get a very different perspective from someone who's out in the waiting room, scheduling, working with patients. And in fact, those interviews had real depth, I think, to the project. So with regard to the first question, a fairly general one. What do you think the components of an efficient clinic are? And people talked about staff. A lot of responses around people, and you'll see that in a second. But more specifically, talked about leadership, which will also play a significant role in our results. Transparency, open communications, setting clear expectations. Training of a staff, that reliability and dedication. In fact, to presage one of the results, we heard from several people who were still using paper records who argued that they were still being very efficient because they took ownership of the referral process. As Sarah noted, referrals are a major problem throughout the safety net. It's not just FQHCs. But people were saying if you take ownership, if you're dedicated, you can facilitate the referral process. Second is the vision aligned throughout the clinic. Do people buy into it? Is there resistance to some aspects of it? If there's resistance, you're not likely to be particularly efficient. What are the partnerships? Who are the collaborators? What we found, by the way, is, for the most part, collaboration is an efficiency, but there are some inefficiencies about it as well. A lot of attention to process, and we'll see that in a minute or so, with appointment scheduling, patient flow, and establishing and following policies as the key indicators. Sarah talked about quality of care. Our results are a little less robust on quality of care in terms of measurement. Not arguing, don't misconstrue, not making any statements about quality. It's simply that our study wasn't designed as a quality of care study. That would really require a separate methodology and probably a different principal investigator. But we'll leave that to Mary Ann for a follow-up. So we tried to define the efficiency domains. And what we did was, after getting the general viewpoint of what makes an efficient clinic, we then handed the respondents a sheet listing administrative efficiencies, clinical efficiencies, and enabling efficiencies. And so we've now collapsed that for this presentation and our report into three domains of administrative efficiencies: people, processes, and technology. And with each of the domains, there is a set of environmental modifiers. And what's important, I think, about the environmental modifiers, and it gets to an important point that Sarah made, physical space and structure are very important in this process in terms of being efficient. And part of the inefficiency is capacity constraint. And that comes up fairly often. And in terms of at least referrals, the linkage to the broader health system is, I think, overall an inefficiency. So the second domain is clinical efficiency. Again, we really don't do much with quality. What we tried to understand was whether they had efficient processes in place for case management, for referrals, and for the free clinics, at least, for managing volunteers. And in continuity of care, as the second aspect of it, looking at coordination of services and referral networks. Finally, enabling services. There, we talked about non-medical care services, transportation, translation, support, community outreach, education, these kinds of things. I actually think these are very important, and though I'm going to talk mostly about administrative efficiencies, let's keep in mind how important these are moving forward with whatever number of patients are served in clinics, particularly the uninsured population, for health literacy, and how we educate them, how we help people navigate throughout the health system. Very difficult even for those who are insured, let alone those who face insurance and other barriers to healthcare. If there's a summary of the findings, and I'm going to actually spend more time on implications later on, we found that measurement, actual measurement, is limited. Now, here's probably the most important divergence from the micro study that we conducted and Sarah's overview and analysis of cost efficiencies. We didn't find the numbers of people using robust measurement to be all that significant. It's not that the clinics aren't measuring, it's how robust are those measurements. The data are clearly there, at least for the FQHCs and for the most part the hybrids, much less so for the free clinics. It's what are the clinics doing with it? What are the measurements? How are they showing efficiencies and cost savings? Finally, one of the interesting findings is that efficiencies and inefficiencies share the same vocabulary. That is, as you'll see in the next slide, what's efficient for one clinic is inefficient for another. So what we find then is lots of variation across clinics, but not a lot across clinic types. So we can't make distinctions by saying, well, FQHCs are efficient along these dimensions, free clinics efficient along these dimensions. Rather, it varies from clinic to clinic. That may well be a function of leadership. That may be where the key variable here is individual clinic leadership, regardless of clinic type. So here's the chart that one of the students put together, which I really like. So here are the key terms on this side, the appointment station, patient flow, coordination, et cetera, and we put checks on each because of the variation that we saw. What's interesting here is note that we don't have anything on costs. it just really didn't come up a lot. So I'm not suggesting that Sarah's points are incorrect. It may be a function of our questions, the protocol, where we didn't ask specifically enough about cost efficiencies. What I would say might be a plausible answer is that all of this, if implemented efficiently, would in fact lead to cost savings. So there may not be a disagreement here at all. How are efficiencies measured? Well, this gets me interesting because we're still working our way through the data. We're about 90% of the way through analyzing them, and we see differences from my presentation at Academy Health, and even from 3 weeks ago. So it's not that there's no measurement. There is measurement. What we're not finding is systematic measurement around key indicators. And that I think is the conclusion that we are coming to, although there's still some disagreement among the members of the research team. There won't be by the end of the report. There is an end to this, right? Yeah. Okay. So you've got benchmarking, you've got length of visits, you've got measurements on an array of indicators. But there's a lot of informal measurement. So it can be as specific as, let's say, I think I have it somewhere in here, volume productivity, time-related, patient wait time, appointment length, clinical quality, HRSA requirements, Joint Commission requirements, patient satisfaction, as vague as, well, we measure the basics. Okay, immunizations, patient wait times. And as honest as, I really don't know. These are direct quotes, by the way. So again, the variation in terms of how efficiencies are measured. So you do get some diabetes-related indicators. You do get behavioral health indicators and productivity measures. When we look at, how am I doing on time? Okay, all right. At administrative efficiencies, not surprisingly, it breaks down into the 3 I mentioned earlier. So I'm going to move on from that. What contributes to efficiencies? Well, you can see here in terms of the numbers, human resources administration are really important process, and less important were things like patient and community factors. Structure, which is interesting, but it should come up more, and culture, which I thought would come up more as well. So again, it may be a function of how we ask the questions. Time was limited. People didn't have 3 hours to spend with us. We could have kept them busy, but they had other responsibilities, obviously. I also like this chart a lot because it makes 2 really important points. First, leadership. Again, I don't need to belabor that. But I think perhaps more importantly is that the block on the left, more efficient clinics had more than one person take a leadership role. Teamwork, division of labor, so that you have leaders setting all of these aspects, transparency, communication, institution.